So there's a lot to say about the young because here. So in 2008, she visited Paris with a small group of radiologists from Israel, and she asked me she was in a hospital in Paris, CSF Dynamics, and she visited a friend of mine, Catherine Benjamin, and when she came back to my clinic, before Shabbat dinner, she said, "Look, who is this girl? She's amazing. Do you think she can teach in Israel?" So as Catherine is a friend of mine, I called Catherine on a mobile phone and I said to her, "You know, Catherine, you have to come to Israel. These guys fell in love with you." And she said, "Are you kidding? I'm not going to Israel. It's too dangerous." And I said to Catherine, are you kidding? Do you think I will tell you it was dangerous? So some weeks later, I think 6 weeks later, we were in Israel for a meeting. And Ruth helped us, and she toured with us, and Catherine fell in love with Israel. She's here every year now, teaching and sharing with me. And so since then, for 8 years now, despite of the 2 years she spent for fellowship in New Bend, she's been helping me a lot, and she's always innovating, and she is very hard worker, and she's pushing and pulling us up and everything like that. So I'm so happy she's teaching with us and part of the team now. And so she will be talking about neurology, so I have to read it. It's Secrets of CSF. Thank you so much.
We'll try to cover many topics, the anatomy of CSF, CSF dynamics, how it looks like on MRI, flow studies and CSF signal, hydrocephalus and GH, intracranial hypertension, and CSF Circulation. The cerebral spinal fluid, or CSF, is a clear fluid that is filling the cerebral ventricles and the intracranial and spinal subarachnoid spaces. The CSF completely surrounds the brain and the spinal cord, and its main functions are buoyancy, which means that it makes the weight of the brain feel lighter. It acts as a shock absorber and acts as a cushion between the brain and the bony cranium, and provides the immediate stable brain environment, supplying nutrients and getting rid of waste. The majority of CSF forms in the ventricular system by the choroid plexus, as you all know. It's a highly specialized network of capillaries projecting into the ventricles. The choroid plexus is found in the floor of the lateral ventricle, roof of the third ventricle, and in the fourth ventricle. The functional unit of the choroid plexus is the villus, that has a single layer of modified ependymous cells, seen here, surrounding a core of capillaries and connective tissue. Between these cells are tight junctions that create the blood-CSF barrier. So there are two barriers that are protecting the brain. The blood-CSF barrier that controls the composition of the CSF and is formed by this epithelium of the choroid plexus, and the massively larger blood-brain barrier, which controls the content of the brain interstitial fluid and has a 5,000-fold greater surface area than the blood CSF barrier. It is formed by the capillary level of the endothelial gap junctions and is also overlapping astrocytes. It limits the passage of larger molecules to the brain, such as gadolinium, for example. And both barriers are dynamic and can be altered by cytokines, interleukins, and antigens in inflammatory and neoplastic processes. So the CSF composition, just as a reminder, is mostly similar to plasma in terms of the main electrolytes and osmolality. However, its concentration of protein is markedly low, lower than the blood, and the glucose is moderately lower. Few lymphocytes or mononuclear cells are allowed in the CSF, but normal CSF should never have no PMN and no RBC. The rate of CSF production is approximately 450 cc's a day, which is roughly like a bit more than a can of Coke. The total CSF volume is 150 cc's in adults, of which the majority is in the subarachnoid space, which is mostly in the fecal sac, and the remainder is in the cranial subarachnoid space and the ventricles. The daily turnover of CSF is estimated at 3.5 times a day. The CSF resorption, just again to remind you, occurs mainly at the arachnoid granulations, which is finger-like inward projection of the arachnoid membrane into the venous system. The arachnoid villi act as a one-way valve that open when the hydrostatic pressure of the CSF in the subarachnoid space is greater than the hydrostatic pressure of the dural venous sinus, creating a passive gradient and allowing the free flow of CSF and larger molecules as protein and blood cells from the CSF to the venous side. Additional pathways of CSF resorption were identified recently via the perivascular spacer, the brain capillary bed, and through the perineural course. It was recently discovered that there is a microscopic flow of CSF in the brain, which is called the lymphatic system, which acts as the brain equivalent to the lymphatic system elsewhere in the body, and which gets absorbed into the venous side in the perivascular spaces. For many years, the only theory about the CSF circulation was the bulk flow theory. This was the concept of passive CSF circulation from the choroid plexus, where it is produced, filling the ventricles, as we can see here, filling the lateral third ventricle, and going to the fourth ventricle. From there, it's going to the subarachnoid spaces, to the fecal sac, and getting reabsorbed by the arachnoid villi to the venous side. This was put together by Harvey Cushing in 1926 and remained unchallenged since, pretty much. However, in recent years, it was evident that the CSF motion is actually not exactly passive flow, but it has a pulsatile nature. The pulsatility is transmitted from the cardiac pulsation, causing to and fro motion of CSF. We can see here a movie taken during endoscopic third ventriculostomy that shows this systolic movement of the CSF across the third ventricle. The pulsatile flow also mixes the CSF, and we see in these spin echo T2 images these low signal flow voids in places where the CSF moves fast, like in the aqueduct, in the foramen magnum, and in the cervicothoracic spinal canal. Phase contrast MRI is a method that can depict signal from moving protons and can also provide quantitative information about the pulsatile movement of CSF. This info is given in cine mode, and I apologize for the quality of this. What we learned from that is that there is a to and fro free passage of CSF across the aqueduct. During systole, the CSF moves down the craniocaudal, and during diastole, the flow is reversed. So this is a normal example of an open aqueduct with a to and fro motion of the CSF. And what about this case with the tectal glioma? Do you think there's a normal flow? No, we see that there's flow in other parts of the thecal sac and the prepontine cistern, but there is no flow through the aqueduct, and there is stenosis. And what about this case? This case is showing the ETV, I mean the passage of between the third ventricle and the prepontine cistern, and we use the flow studies to assess if it's patent. And what do you think? Is it patent? Yes, we see here the normal to and fro. Comes as a cinemode in real life, we still have that. And we see we can establish patency very easily with this type of studies. What about the normal CSF signal in MR? The normal is bright on T2, dark on flare. And when it is flare bright, it is abnormal. And that can happen from a number of reasons. The most common is subarachnoid hemorrhage, and this is more sensitive than CT in depicting that, as we can see here. It can happen in meningitis, leptomeningeal neoplastic spread, like we can see here in this case of melanoma, that also enhances. And there's a bunch of artifactual reasons, like inversion recovery calibration issues, adjacent metal. So we have to, whenever we see a bright signal on CSF, we have to make sure that the clinical context matches and it's not an artifact. Other things that can cause the MR bright signal is the supplemental 100% oxygen and gadolinium injection. So we move on to pressure. The pressure of the CSF is a balance between CSF production and resorption. The normal is approximately 15 centimeters of water in the supine adult. It's measured in the lateral cubitus position. Obese people tend to have normally they tend to have a higher pressure. And increase is above 25 centimeters of water. There's many things that can lead to elevated intracranial pressure. Basically it's increased brain volume, such as hemorrhage, fast-growing tumor, abscess, cerebral edema, increased blood volume that can happen from obstruction of the venous outflow, hyperemia due to hypercarbia, and increased CSF volume due to increased production, decreased resorption, or obstruction, such as in cases of tumor or aqueduct stenosis. And that can also lead to hydrocephalus. And we move on to hydrocephalus. I'm sorry if it's a bit basic for some of the people here. So the hydrocephalus means excess water in the cranial vault with dilated ventricles. The condition is frequently divided into non-communicating or obstructive hydrocephalus, when obstruction occurs at the level of the ventricles, and communicating hydrocephalus, where the pathology is distal to the fourth ventricle, usually at the level of the anastomoid vein. They both present with increased intracranial pressure. There's a subset of communicating hydrocephalus called the NPH, or the normal pressure hydrocephalus, where the ventricles are dilated, but the intracranial pressure is normal. The most sensitive indicator for early hydrocephalus on imaging is the acutely angulated anterior recesses of the anterior third ventricle. As you can see here, this is the suprachiasmatic and the infundibular recess. In this case of early obstructive hydrocephalus due to tectal glioma, we can see rounding of these structures and depression of the floor of the third ventricle. And that can indicate early hydrocephalus. On axial images, we will see that the same finding as the dilatation of the anterior part of the third ventricle, also called the light bulb sign. Other points to remember about hydrocephalus is that ventricular enlargement is best assessed in the smaller temporal horn and third ventricle, rather than assessing the big lateral ventricle. we should always look at the relationship with the suicide, as enlarged temporal horn can also be the result of cerebral volume loss, as in this case. And also, we should assess for transappendicular CSF edema that indicates the acute non-compensated hydrocephalus, and it's best enunciated. And we move on to some examples of non-communicating hydrocephalus with different level of obstruction. Here, the obstruction is in the foramen of Monroe, causing only dilatation of the lateral ventricles, like in this case of hypothalamic myoma. Notice also the transappendicular CSF edema. And in this case of choroid cyst at the roof of the third ventricle. Okay, so when the obstruction is at the level of the aqueduct, the third and the lateral ventricles will be dilated, as we see here in the case of craniocephalus and aqueductal stenosis. When the distal part of the aqueduct is the one to be stenosed, we can also see the wedge sign, and that helps us to localize the exact location of the stenosis. When the obstruction occurs at the level of the fourth ventricle, at least in this case of medullostoma, also the lateral ventricles and the third ventricles will increase in size. However, the aqueduct will now have a parallel wave shape, and that can also help us to determine. Okay, so communicating hydrocephalus, as most of you know, is usually the result of diminished CSF resorption at the arachnoid granulation level or subarachnoid level. It occurs most frequently after subarachnoid hemorrhage or infection, and this is a typical case of massive subarachnoid hemorrhage that 6 months later develops a non-communicating hydrocephalus. And we move on to NPH. NPH is an ambiguous, controversial entity. The diagnosis remains even until today, but still we have some utility of the imaging. It's classically characterized by the non-specific triad of gait apraxia, which is usually the first symptom, urinary incontinence, and dementia, although not all patients have all three. When it was first described in 1965, it was described as idiopathic. However, since then, a subset of secondary NPH, secondary to prior hemorrhage or meningitis, was discovered. These patients tend to be younger and respond better to shunting. The classic imaging hallmark that we look for is dilatation of the ventricles out of proportion to the sulcal enlargement. The third, it's mainly the lateral and third ventricles that are enlarged, and the fourth is relatively normal. The pathophysiology of the ventricular enlargement is still controversial. There's theories about decreased CSF resorption, and there is theories of weakening of the ventricular wall due to periventricular white matter ischemic damage. Whatever the reason for the ventricular enlargement, these large ventricles cause hyperdynamic flow of CSF across the aqueduct when they contract with the cardiac cycle. And that causes, we used to see this hyperdynamic jets across the aqueduct in here, which was suggestive of the diagnosis. Now with the newer face contrast MRI flow studies, you can see in the axial plane, for example, you can see here, dilated aqueduct with increased flow. NPH treatment, shunting is the main treatment, but careful selection of patients is needed. The NPH is potentially reversible if the symptom is less than 2 years, and it's mainly gait disorder. To assess if the patient will respond to shunting, we can either do a tap test, where we remove high volume of CSF and assess the gait improvement, or we can measure the aqueductal stroke volume, which means the amount of CSF that cross through the aqueduct in a given time. It has been shown that values that are double the normal and above that tend to have better response to shunt and favorable outcome. Okay, so pseudotumor cerebri is another entity of CSF dynamic disorder. This is a syndrome of signs and symptoms of, that are derived from elevated intracranial pressure in the absence of SOL or other causes. The name benign intracranial hypertension should not be used. It was actually replaced with pseudotumor cerebri that people didn't like either, but that also should not be used because approximately 2% of the newly diagnosed pseudotumor can develop blindness in the first year. So the preferred terminology in the literature today is the idiopathic intracranial hypertension. As we know, the symptoms is the most common symptom is headache, and it can also be the other symptoms are transient visual obscuration, also tinnitus, diplopia, and sustained visual loss. Papilla edema is very, very common, as we see here, and sixth nerve palsy is less common, but we need to know how to recognize this also from the imaging. Here the patient is, we can see that the patient is, this eye is normal, and he has a sixth nerve palsy on the right, and he cannot abduct his eye and go to the right. Okay, so the general population, the IIH is, the incidence is about 1 to 2 per 100,000, but among women that are young with obesity or fast weight gain, it's very common. I mean, it's much more prevalent, 18 per 100,000. So the typical patient is an obese young woman. The pathophysiology is unknown, but the current theories of impaired venous hemodynamics and increased venous hypertension. So there is a vicious cycle of venous, and that's what's described. It starts at the stenosis of the dominant or both lower sinuses, which then causes decrease in CSF resorption, which can elevate the intracranial pressure and cause further venous collapse. Okay, so onto the imaging side. So the empty cella is one of the most prevalent imaging signs of IIH. It has a very low value as an isolated finding, as we can see that in many older people scans. So we'll put it in clinical context. The finding has variable degrees, pituitary compression, partial empty cella, and complete empty cella. Here seen as enlargement of the pituitary fossa and herniation of the supracellular system with the apparatus. The orbital findings in pseudotumor include the posterior scleral flattening that is very common finding. The optic sheet dilatation, which we tend to measure more than 6.5 millimeters immediately behind the lobe, and the well-known optic nerve tuberosity. As I said before, papilla edema is very common, so optic nerve protrusion on the MRI is frequently seen. We can pick that on T2 or flare most commonly, but there is another finding of pre-laminar optic nerve enhancement that is less prevalent but is more specific, and the post-contrast one. Reversible stenosis of the distal segment of the transverse sinus is a well-established sign. We can see the typical findings that we can see is a smooth tapered stenosis of the distal segment of the transverse sinus. It can be unilateral or bilateral, and is best shown in contrast enhanced MRI. It is reversible. When the pressure decreases, it disappears, and it's prevalent up to 90%. Additional finding, skull-based meningoceles of all types here seen in the middle cranial fossa, and arachnoid pitting. The available treatments for IIH include the medical treatment of diamond, repeated LP, shunts, optic nerve fenestration, and transverse sinus stemming. So this is a case that we have of a 22-year-old female that was obese with untreated hypothyroidism. She suffered from severe headaches and blurred vision. On exam, she had papilledema, and the opening pressure was 32. Diagnosis of IIH was made clinically. Also, her images showed the disc optic nerve disc protrusion and the classic transverse sinus stenosis, also in the dominant and the non-dominant side. This patient continued to deteriorate despite medical treatment and repeated taps, and she underwent successful stenting of the dominant transverse sinus with marked improvement, reversal of the papilledema, and reversal of the sinus stenosis. So, I'm going to talk about intracranial hypertension. So intracranial hypertension is a syndrome that we also need to see relatively often in the clinical practice. It's a syndrome of low intracranial pressure, CSF volume depletion. This is an under-recognized cause of headache syndrome. MR is very diagnostic and leads to the correct diagnosis and treatment. The low pressure may cause downward cooling of the brain and the cranial nerves. Subdural fluid collections, subdural hematomas, where there is enough cooling of the rigid veins to cause subdural hematomas. Sinus extension, and then when thickening is all of these signs may normalize when there's intracranial when the situation resolves. Hypertension can be spontaneous, usually due to spinal CSF leaks from the thoracic fecal sac level. And the usual cause is the ruptured nerve root sleeve cyst and the small dural tears, and more common in women and linked to connective tissue disorder, and can be secondary to traumatic and iatrogenic causes. And the most common iatrogenic causes are lumbar puncture that pierces the dura, spinal anesthesia, neurosurgery, and shunts and drains. A 10% in the reduction of the CSF volume will result in headache, and the headache is typically orthostatic. It shares common features with post-LP headache, but it's more long-lasting and more severe. Other symptoms that can happen are nausea, diplopia, again, like the intracranial hypertension, vertigo, tinnitus, and hearing loss, and shoulder and back pain. Also, the patient can show memory loss, stupor, and even coma and death. Okay, so regardless of etiology, the hypertension has distinctive imaging findings like this was a case of a 36-year-old woman that had 6 months orthostatic headaches. Her MR showed diffuse dural enhancement, and her mid-sagittal MR image showed the classic signs of intracranial hypertension, as you can see here. And these are the sagging midbrain and the decreased mammary pontine interval, the flattened points in the effacement of the prefrontal cistern, the cerebellar tonsillar descent, the descent of the splenic of the corpus callosum, the enlarged pituitary, and the enlarged convex dural venous sinus. dilated veins can cause sluggish flow and elevate the risk of sinus thrombosis. This 24-year-old woman was 5 days postpartum, and she underwent epidural anesthesia and presented to the ER with severe headaches and vomiting and seizures 5 days later. Her MR was positive for the classic hypertensive signs of dural enhancement, subdural collections, and even hematomas. But she also presented with extensive venous thrombosis and even venous infarctions. We showed in a recent study that we did that the hypotensive state added to the severity of sinus thrombosis, especially in postpartum stage. The spinal manifestation of intracranial hypertension are less common. Imaging may show spinal fluid collection and epidural venous plexus, multiple meningeal diverticular or nerve root sleeve cysts, and in cases of spinal CSF leaks, we can see fragments of stabilization in some cases when we do MR myelopathy. The treatment of spontaneous intracranial hypertension is epidural blood clot that is effective in more than 75% and is the first line of therapy before imaging or surgery. Just to run through the skull-based CSF flicks, the CSF flick can occur not only on the spinal level but also in the skull-based level. This is usually traumatic in origin, which can be iatrogenic or accidental. The usual manifestation is the rhinorrhea, but it can also have the manifestation of otorrhea or cirrhosis of the media. Beta-2 transferrin, which is a peptide that is found only in CSF, is checked in the nasal or ear secretions and is very specific, and there is increased risk of meningitis. The skull-based leak sites, sometimes they are very hard to find, and what we look for basically is very small bony defects that usually occur in the anterior cranial fossa, in the prebriefing plate area in the roof of ethmoids, and in the middle cranial fossa, in the lateral sphenoid sinus, or in the tegmen tympani. The usual workup that we do is the high-resolution CT for the skull base to look for these bony gaps and preferably an opacified sinus next to it. Coronal images, MR and T2 images to look for associated meningoencephalocele, and you can also do the MR, CT, and nuclear cysternography. Just to show you the case, this was a 45-year-old woman who presented with seizure, and her history was also remarkable for occasional CSF rhinorrhea since childhood. We see in the CT a large bony gap with that prompted this MRI that shows the brain herniating down to the nasal cavity, and the diagnosis of frontocoidal encephalocele was made. She underwent a section of that segment of the brain and repair with flap, and she did well. This was a recent patient that presented to our hospital with bacterial meningitis. Her CT showed a bony gap in the lateral recess of the sphenoid sinus, and her MR showed a new CT. This is the last example of a case of a tegmen tympani meningoencephalocele found this is found in a 58-year-old woman with recurrent seizure and cirrhosis of its media. The MR is showing the fistulous connection between the middle cranial fossa and the middle ear and mastoid air cells, and the CT is going to show you the bony erosion. Post-surgical CSF leaks are common quantification of sinus surgery, transfemoral surgery, skull-raise procedures. They pose a severe problem to the surgeon. That when I asked one of the surgeons in my hospital, he said that the CSF is the surgeon's best friend during surgery, but his worst enemy after surgery. When it's immediate, a few days after surgery, what they try to do is the CSF diversion. They put continuous lumbar drain for several days and see if the CSF leak stops. And if it doesn't, they need to go back in and do patching of the site. So this concludes my talk. We discussed a lot, but there's much more. There are many new developments, and there's a lot of new MRI techniques, developments in the molecular biology, and we look at many clinical entities now in the context of CSF flow dynamics, like in this PR1 malformation case. Thank you.
Thank you so much for this nice, amazing lecture. And these beautiful pictures, even for me. With no muscles and buttons, it was nice.